beauty. It's watching it for information. Okay, there we go. Recording it. And I learned from the last time I did a recording that I need to not move so quickly because it's nauseating. Did you notice that? You didn't think it was nauseating? I went back and looked at how it looked and I thought, whoa, I need to not move so quickly in between. Okay, I want a slideshow. Okay. So go ahead and write the words for this first, and then we'll talk about what does this mean. What is the meaning of osmotic pressure? And this is the second of the two pressures that control fluids going in and out of capillaries. So hydrostatic is the first, and then the second one is osmotic. And those are two really different things. And they're kind of opposites of each other. So once you got these words written, I'm going to go back to the previous slide and just remind what was hydrostatic and what was that situation, and then compare this one to it. If I stand right here, the owl will pick up these words. So they will appear on the video. Okay, so let's look back at the previous hydrostatic. So we talked about last time that hydrostatic pressure is blood pressure, basically, where your left ventricle is pushing blood through vessels under pressure. And when that blood hits a capillary bed where you've got leaky slits in the walls, fluid is going to get pushed out this way. And every small thing in the plasma that can dissolve in plasma is also going to go out into this area next to a body cell that needs that material. So osmotic pressure is also a force that is acting on fluids in the capillary beds, but it's moving fluid in an opposite direction. So we would call, in this case, we've got fluid and dissolved substances going back into the capillary, moving from outside to inside. And we call that process reabsorption. We're reabsorbing fluid back into the capillary. And this is a good thing because if you didn't do reabsorption and you only pushed fluid out during filtration, you would eventually run out of liquid in your blood. So you need to get some of the fluid coming back in. And that does happen. It's called reabsorption. And it's coming from this property called osmotic pressure. And this is basically osmosis. It's the same thing as osmosis. What did you memorize sometime before about what osmosis is? Diffusion of water. Yeah, it's diffusion of water. So it's movement of water. And the water basically is the fluid and the dissolved things in it coming back into the capillary. The other thing that you need to know about osmotic pressure to understand it is what's doing the pulling. So what's doing the pulling, so we've got water and solutes are going to be pulled by the large what do we want to call it? Large particles that stay in the capillary. That's what's doing the pulling of the water back in and causing osmosis and providing an osmotic pressure. So those large particles that stay in the blood that's going to be anything that was too big to leak out. So that's going to be big stuff in the blood. That couldn't fit through those capillary slits. Too big to get filtered out. And that would include all blood cells. All the blood cells, all the platelets, and then this other set that we would call large plasma proteins. Big size proteins that can't fit through those slits. All of those things are pulling water back into the capillary from outside to inside. So there's filtration from blood pressure pushing fluid out, but there is also osmotic pressure pulling water back in, and those two forces are going to balance each other. So I'm going to draw over here a capillary. And kind of repeat these arrows. So there's a force going outward, and there's also a force pulling inward. And I want you to also draw those arrows going in the other direction too. Force outward and a force inward. We're going to come back to this next. They've got it there. What is the normal value? I have that on the. Okay. Here. What I want you to write in that space about normal value is just that normally osmotic pressure is lower than the hydrostatic. So its amount of force is not as great. And I think the numerical value of that we're going to see on the next slide. How does this seem so far? I was telling Han this morning, like, I gotta record this lecture because this is a tough thing and no one's ever heard of it before they come to this class. And I hadn't heard of it before I started teaching this class. But this stuff, it happens every capillary bed in your whole body. And it's important for multiple topics in A&P2. So this relates even to this graph. So when we're looking at the pressure of the blood and how it drops when you get into the capillary beds, this stuff is why the pressure drops. So here's the blood under pressure. It enters the smaller arteries and it moves through arterioles, and then it comes to capillary beds that are leaky. So if you've got this picture, you should write on the purple part right here, leaky. That's when fluid can start leaving the blood. And as the fluid leaves the blood, it makes the pressure get even lower. Pressure is going to get even lower because fluid is moving outward as soon as the blood comes in and hits these capillary slits. So you're going to leak fluid and have filtration happening. And that makes the pressure even lower than it was. Fluid leaking outward. So on this picture over here, where we've got the arrows pushing outward, make an H on that for hydrostatic. It's not up. See how on these pictures are like the arrow's pointing up. It's not leaking up, it's leaking out of the capillary, outward. And every time blood hits a capillary bed, fluid's going to start leaking outward because of hydrostatic pressure. As the blood kind of keeps moving through the capillary bed, in the middle of the capillary, there will be some outward and some inward coming from osmotic pressure. But in the middle of the capillary, those pressures kind of balance out. Pressures balance out. And playing this part down at the bottom. So at this position right here, the hydrostatic pressure is 35 millimeters of mercury. That's just a unit outward. And the osmotic pressure, which is not shown on here, is 25 millimeters of mercury inward. So there is osmotic pressure at a lower amount pushing inward than the hydrostatic pressure pushing outward. I'm going to use the whole thing here. So this arrow here is depicting, it says it's +10, that's the net pressure. The net combo pressure is 10 outward. 10 outward. In the middle of the capillary bed, the hydrostatic pressure is lower than it was because fluid has leaked out. And the osmotic pressure stays the same. So you have a net pressure of 0. They're balancing each other out. You have a 25 pushing out, 25 pulling in, so the overall movement of water in the middle of the capillary bed is 0. By the time you get to, we'll come back to this. By the time you get to the end of the capillary bed, the hydrostatic pressure has kept on falling even more. 18 outward, you've still got 25 inward. If you have a value of 18 pushing out and 25 pushing in, the difference between that is 7. 7 in an inward direction. Which means if your capillaries are acting normally, by the time the blood gets toward the end, toward the vein end out here, overall there's more fluid coming in than is leaking out. Complicated stuff. So to kind of recap, what is the implication of all of this? Let's go back to this. So this is hydrostatic pressure. This graph is what is the blood pressure throughout the system. It is the hydrostatic pressure. And notice the pressure drops along the capillary bed because they're leaky. And the hydrostatic pressure at the beginning is higher than it is at the end. Because you've got fluid leaking out all that time. So that fact is always true about a healthy capillary bed. So in a capillary bed, or in capillaries, the hydrostatic pressure falls from beginning to end. because you've had fluid leaking out all this time. But the osmotic pressure stays the same. Because it depends on big stuff that never left the blood in the first place. It's always in there. It's a constant pulling force to get fluid back in. So the osmotic pressure remains the same. It remains constant. Because it depends on those large particles that never leave the blood. Remains the same. So as you look across from beginning to end of the capillary bed of the capillaries, the osmotic pressure stays the same. It doesn't change. And in this scenario, it's 25 inward. 25 inward. The hydrostatic pressure comes in higher at 35, and in the middle, it's going to balance out. And then toward the end, it's low. So in the beginning of the capillary bed, you lose fluid. At the end of the capillary bed, overall, you regain fluid. Pulls it back inward. So this is how I ask about this concept on the exam. How I ask about these. So it's related to this figure right here. So we know that hydrostatic pressure is always directed outward. Osmotic pressure is always directed inward. What I will ask you on the test is I will give you values for those two numbers. So if hydrostatic pressure is blank and the osmotic pressure is blank, what is the net pressure, both the value and the direction? Value and the direction. That's how I set up these questions. And I'll give you two numbers. So I want you to work on the first one and make up some numbers here. Let's say the person has high blood pressure and their hydrostatic pressure is 40 at a certain point, and their osmotic pressure is 29 because they eat a lot of salt. Those two numbers. What is the net pressure and the direction? So work on that for a couple minutes. Talk to your neighbor. Think about it quietly if you're like an independent worker. See what you get. That's an example. There we go. That's the example problem, the first one. And I'm putting those numbers on this picture because I like pictures. They help me a lot. Okay, this is the last slide in this set. Who has a net pressure value? Anybody? Mm-hmm.
11 inward.
11. It's definitely 11. It's gonna be outward. So the net pressure is always gonna be the difference between those. What's the difference between them? So these are 11 apart. And the way that you figure out which direction is you take the direction of the bigger pressure. So this answer would be 11, and the unit is millimeters of mercury, and it would be outward. How do I know it's outward? Because hydrostatic is always pointing in the outward direction. And osmotic is always pointing in the inward direction. So you take the difference between those, and then you go with the dominant direction. Does that make sense? Your book uses positive and negative numbers, and I don't like that because I need you to know what the negative number, I want you to know, is it going outward or is it coming in? Is fluid leaking or is it fluid returning? So let's do another example. Also, don't call it up. It's outward. So it's out of the blood and into the tissues. So let's do another example. And you can make up whatever numbers you feel like to practice these. Later on. Okay, let's say the hydrostatic pressure is 18 because the person is like hemorrhaging. They got really low blood pressure for some reason, and their osmotic pressure is 25.
And inward.
Yeah, hydrostatic is 18 is the value of their blood pressure, 18. And the osmotic pressure is 25 for this person. Or actually, I copied the same problem. Didn't mean to. That's the situation. What would be the net pressure in what direction? 7 inward. Yeah, so it'd be 7 millimeters of mercury, and it would be in the inward direction. How do you know it's the inward direction? It's that the osmotic was the bigger pressure, and osmotic is always directed inward. So the overall movement of fluid is going to be inward. If you go past this class and you see about these things and they're using a negative number, that means that the fluid is coming inward. I'm not going to use that system in this class, but the movement of fluids in and out of capillaries is basically how your kidneys work, and it affects a lot of other things. So what I will ask you on the test is this type of problem. Tell me if I give you these pressures, what's the net value, and is it inward or outward? And then also some questions about what is hydrostatic pressure and what is osmotic pressure? Why do they happen? That's going to be that section of the test. Let's do one more. If the hydrostatic pressure 38 and the osmotic is 20, what would be the net pressure and the direction? 18 outward. 18 outward. Yeah. 18 outward. So practice some of those. That section on this next exam is probably like 6 or 7 points or something like that. So set up in that way, and some questions, they're asking you, like, do you understand what hydrostatic pressure actually is and what osmotic pressure actually is? So it seems like next we're going to a whole different topic, but it's directly related to this capillary bed topic. And I'm not putting the quiz questions on a video. I will go back to those after I turn off the recording, because I'm with it today. Thinking ahead, okay. So lymphatic system starts with the leaked fluid. All this fluid that just leaked out of our blood in the capillaries. The lymphatic system starts there. So when we have fluid leaking out and coming back in by osmosis, by the time we get to the end of the capillary bed, not all of the fluid ever came back in. So we had an overall loss as the blood moved through the capillary bed. We got some of it back by osmotic pressure, but not all of it. And your lymphatic system, one of its big jobs is to return that fluid that leaked out, get it back into the blood eventually. So that's one of the major jobs. The second major job is to monitor that fluid for things that might be harmful to us. That's job number 2. And job number 3 is to move lipids between the digestive system and the blood. That one we'll come back to more when we get to the digestive system. Everything about your lymphatic system is set up to accomplish those jobs, but I first want us to draw something into this picture right here that's going to relate to the next cartoon. So here's the blood coming through the capillary, and we've got body cells out in this area that need stuff from the blood. Got cells. And then out in this area is this fluid that has leaked out. So there are a couple different names for what we call this fluid. It can be called interstitial fluid, or it can be called tissue fluid. And different books call it both those things, and I tend to say tissue fluid because it's easier, but those are the same stuff. And what this is basically plasma and all that small stuff dissolved in it. Those are all 3 basically the same thing. Plasma with its dissolved stuff. If it's inside, if it's outside, we call that interstitial fluid or tissue fluid. And the other thing that's in this vicinity, lovely, this green thing. Anywhere close to where you have capillaries, you have lymphatic vessels, or what they're calling here, lymph capillary. It's going to be nearby. It's a much nicer picture. Having multiple versions of pictures helps you learn them. So everywhere we've got capillaries, we also have these lymphatic vessels or lymph capillaries that are in the same location, and they're kind of running parallel to the bloodstream. And your book colors them green, just so that they look obvious. They are not green in your real body, but they're colored green in the book. And they're kind of reaching out into the capillary locations so that they can pick up the leaked fluid. So what's supposed to happen is that this fluid that leaked out is supposed to get into the lymphatic vessel and eventually return back to the bloodstream. So I'll do 2 arrows to indicate it's eventually. They're gonna stop. I don't need to be monitoring for spam right now. Eventually, these are going to carry the fluid back to the bloodstream. And you got these lymphatic vessels reaching all over your body. There we go. So next we're going to look at, okay, how do they pick up the fluid? How do they do this? How does the fluid get in there? And we've got a close-up of what one lymphatic vessel looks like. So it's got these certain structures that allow it to pick up fluid. Firstly, these vessels are called blind-ended, and that relates more to this previous picture. Go backward, yeah. So see how these kind of come to an ending and then they stop. They have an ending. They're not a continuous loop like blood vessels. Having an ending like that, that's called being blind-ended. And the way that the fluid gets in there is that the cells that make up the walls of the lymphatic vessels, they also are leaky and splitty. And when the pressure of the fluid builds up, it will drift in there. So even the walls of the lymphatic vessel are acting like one-way valves that fluid can seep in through the walls and make it into the lymphatic system. And once the fluid gets inside the lymphatic vessel, then we call it lymph, L-Y-M-P-H. So all of these things are about the same. So plasma, tissue fluid, which we could also call interstitial fluid, and lymph, basically are having the same components. They're water and they're the small dissolved stuff, but we call them a different name based on where they are found. Like if you're out by the track, it's called Volunteer Parkway, but if you keep driving on that road, eventually it becomes Commonwealth. And then eventually it becomes like an exit of I-81. It's the same thing. It's just changing names depending on where it is. So if it's here, the fluid's here, it's plasma. If it's in this in-between area, it's tissue fluid. If it's in the lymphatic vessel, it's lymph. And it can get in because of having those little one-way flaps in the walls to let the fluid in. So the lymph is basically plasma, but by the time it gets into the lymphatic system, it could have other stuff in it that got in there from the tissues. It could pick up foreign objects when it was in the tissues that also make it into the lymphatic system. So as the lymphatic vessels are on their way to connect to the bloodstream, they are going to pass through these stations called lymph nodes. then make it eventually back to the bloodstream. And this is a picture of a lymph node and the different regions and so on. You don't have to know the regions for this class. But in the lymph node, there are some white blood cells, part of your immune system, that are screening for dangers to see, like, are there dangerous particles passing through this station? So to me, lymph nodes are kind of like airport security. Like, you can't make it further unless you pass through the security and get screened for danger. So you have white blood cells in your lymph nodes that are going to screen the lymph for dangers like bacteria, viruses, other foreign particles. They're screening stations. So this picture of the lady is kind of showing where people tend to have lymph nodes. So I'm gonna draw some circles around important places where people have lymph nodes. So they tend to be, you have several on the sides of your neck. You have really a lot in the armpit or axillary region. You have some toward your elbow, toward the back of your knee, a bunch in the groin, and then a bunch that kind of near your digestive organs. So they're not evenly spread out over the body. The security stations to screen lymph are kind of at the junctions of your body. So between the head and the torso, between the arm and the torso, between the leg and the torso, and then you've got some near your digestive regions. Those are the major places where we have lymph nodes. They are not really glands. You might hear people say, like, oh, I think I'm coming down, so I got swollen glands in my neck. They're lymph nodes. They're not actually glands, but they can swell up. So the time when lymph nodes are going to swell up is when they have a security alert. There's foreign objects detected. And the reason that they're swelling up is that more white blood cells are going to come to that lymph node and try to assist with the immune response to whatever dangerous thing was just discovered there. So like, if you're, oh man, this is embarrassing. When we came back from Malaysia, or maybe it's one of those internal flights, one of the boys had bought a butterfly knife comb. You know what this is? So like, some kind of knife, they make knives like this, you like flip it open dramatically and there would be a knife. But this was a comb, but it looks like a knife. So we get on the, like going through security, get on the internal flight, and like the thing beeps in the detector and they're like, come over here, come over here. Like, fortunately, it's a little kid, obviously, and like it is a butterfly comb, but they took it away and it was so embarrassing. Now it will join the collection of confiscated items. But if that had been somebody with a gun, imagine how many security officers would come. Like, can you come over to gate 13, we have a situation, and more people would come there. Same thing with white blood cells. If you detect, oh, we have a foreign object in this neck lymph node right here, white blood cells are going to migrate there and accumulate and try to help with the immune response. And that's why the lymph node would swell up. Something I want to add on to this figure. Yes, add on to this. Is where those lymph nodes are draining. Where are these lymph nodes? What body regions do these drain? And let's start with up here in the neck. So if you have swollen lymph nodes up here in your neck, where did the problem come from? I don't think this is obvious, actually. It could be from your tonsils. Where else could it be from if you've got neck lymph nodes that are swollen up?
Mine always slow,
Always?
like if I'm getting sick, every month.
What kind of sickness?
Okay, this time last year I got one,
Mhm.
when this happened, when I got COVID,
When you got COVID?
and
Yeah.
spread too.
And strep, yeah.
it's-
It's not actually every sickness, but it sounds like you tend to get upper respiratory
Yeah.
stuff. So if you've got swelling here, the problem or the infection is coming from your head and neck. And the reason that those tend to swell up so much is because a lot of our illnesses, we breathe it in, we
Yeah.
swallow it, and that's where the problem is. So that's where the foreign objects are getting into the lymphatic fluid or the lymph, and then they start traveling down, and that's where they get detected, and that's where it swells up. So if you, so you know, you go for a checkup and they like feel your neck lymph nodes. Part of it's for thyroid, part of it's to feel if you've got swollen lymph nodes. And if you do have swollen lymph nodes, the follow-up question is, how are you feeling today? Or like when they ask you, why'd you come in here today? And if you said, I've got upper snot and so on. Doctors and nurses and practitioners get really scared if they feel lymph nodes swollen up and you say that you feel fine. Like if there's no infection up here, because the reason that that scares them is the other thing that can appear in lymph nodes is cancer cells. If cancer cells are growing somewhere silently, then they break off and they start traveling around the body. They can also cause lymph node swelling. And if you've got swollen lymph nodes in the neck with no known infection, where do we worry about the cancer being? Brain. And a lot of people's brain cancers are actually detected this way. And it's just like a terrible feeling if your patient's got really swollen lymph node and no infection, no damage. They may have a brain tumor. What about here? So if your lymph nodes in your armpit are swollen, where is the problem coming from? Could be the chest area. So it could be coming from this side of your chest, or it could be coming up your arm. It'd show up very good. Could be either place because there's kind of a junction there. If we don't always see when people have a swollen lymph node in their groin, and that's a more awkward thing to check. But if you have lymph nodes swelling in the groin, it's normally the problem is coming from your leg. If you had swelling behind your knee, the problem is coming from your lower foot. So something that's helpful about this to know is that all the lymph is moving toward a certain spot in the body. Which is right here. Really, this slide should come before what I just talked about. So a lot of words to write. All like that. So the lymph, which used to be tissue fluid, which used to be plasma, it's at really low pressure in this system. So the way that we get lymph to move in the body is kind of the same ways that we get blood to move through veins. So your big lymphatic vessels will have valves, and our muscle actions help to push the lymph along through the system, and so does the respiratory pump. And the other cool thing about lymphatic system is the fluid is moving basically back up near the heart. So got a blow up here of your subclavian veins. So under your clavicle, subclavian veins. And that's the places where all the lymph is moving toward. So lymph from, they've got it color coded here. So frustrating. The parts of the body color coded purple, all of that lymph coming from those places is heading for your right subclavian vein through this big lymphatic duct right there. And everywhere else in the body, the lymph is eventually moving into the left subclavian vein. So that's where it's heading. And knowing that, then you can kind of think, oh yeah, so lymph from this leg would be basically moving up this way. Lymph from this side of the head is moving down this way. Lymph from this arm is moving up this way. So subclavian veins are the destination, and that's where the lymph is going to rejoin the bloodstream. So the fluid is going to rejoin the bloodstream at the subclavian veins. And that's kind of useful because that adds a little bit of extra fluid push into the blood and also help the blood make it the last few inches back to the vena cava. Then all that fluid rejoins the blood. Something that a place that you will hear about lymph and lymph nodes a lot, either in your career or just in the life of you and people that you love, is when people have to have lymph nodes checked near a cancer. And we call that a sentinel node biopsy. And this is looking at lymph nodes. If we know that a cancer is in a certain location and we want to know whether it's spreading, is it moving from that spot elsewhere? And to do that, we have to determine what is the sentinel node. So sentinel node means what is the lymph node that is nearest or is draining the tissue fluid where the tumor is. That's the lymph node we want to look in to see, has cancer come into this lymph node and do we have some cancer cells stuck in there? This is really common for breast cancer, true for other cancers as well, but this is the most common one. So if a woman or man, men can get it too, can get it too. But if, say, like, for example, if the tumor was, right here, kind of high up, it's not actually obvious, which lymph node would be draining that region, because people's lymph nodes aren't consistent between people about exactly where they are. So, like Alexa may have 12 in her armpit, and I may have 11, and they wouldn't be exactly the same spot all the time. So the way that you determine what's the sentinel node is that you inject a dye or sometimes real mild radiation into it and let that kind of diffuse around the tumor, and then track it and see which lymph node did that end up with. Which lymph node did that end up in? And then that's the one to take out or to biopsy. So if that was the one that the fluid leaked into, we're going to what the body and check for cancer cells. And that's when you send it to the lab and they look under a microscope and they look for cancer cells. And what you want is that you don't see any cancer cells. And if you don't, you can be pretty sure that that tumor is just only in that spot and it's not sent cells out to the rest of the body. If you've got cancer cells in that lymph node, it means that the cancer is probably spreading. And we said that that's a malignant, that would be a malignant tumor. And in that case, the person is going to need chemotherapy or drugs all over their body to try to get to those cancer cells that have spread. If the person has a tumor that is not spreading into the lymph nodes, you could remove it surgically and then maybe do radiation to that area, and maybe they wouldn't have to have chemo. But that's a place where lymph nodes comes up. The other thing I want you to know about this, is this the last slide? Is there one more? Yes. It's actually not that slide. Well, we do need to include this, I guess. We do. We got these other two organs that go with the lymphatic system. That we don't think about too much. So we have this organ called thymus that is part of the lymphatic system, and it's not the thyroid. So you've got thyroid up here in your neck, slightly lower down, overlying the heart, you have thymus, and they both start with thigh, and they both have a butterfly looking shape, which is kind of unfortunate. But what the thymus does is it is like a school for producing white blood cells called T lymphocytes. So it is it grows and matures white blood cells called T lymphocytes specifically, and they're called T because they come out of the thymus. The time in our life when we make a lot of T lymphocytes is before we're 12. So even by your all's age, your thymus has shrunk down a lot because you've already made the T lymphocytes that you need, and they live a long time. And then by my age, it's really small. And then in actual old people, it's almost gone. So it's considered part of the lymphatic system because it produces white blood cells that participate in the lymphatic system. And then now we should be basically, no, I skipped one, spleen. spleen. So your spleen is doing for blood what a lymph node does for lymph. And it is on your upper left torso wall. It's really dark red. It's on those models down there. Have you had that on the diagram yet or something? Like sometimes we forget to tell y'all, this is spleen right here, dark red, and it's filtering blood. So it's going to remove old red blood cells or damaged red blood cells out of circulation and recycle their parts. If people have sickle cell, that works their spleen overtime because they've got a lot more damaged red blood cells and it might cause their spleen to rupture. But spleen is sometimes considered part of lymphatic system too. And then final slide. Some other tissues that you have that are part of lymphatic system are your tonsils. That is what tonsils are. They're lymphatic immune system tissues, but they're kind of like lymph nodes. And they are screening items from your mouth. So you have tonsils at the back of your throat that are screening what just came into your body and find out if it's dangerous. And you also have them down in your gut as well. Those are kind of newer. And those are called MALT, mucosa associated lymphoid tissues. So if any of you had your tonsils out, when I was your all's age, people thought they didn't do anything and nobody needs them. It's like, they're just a problem, just take them out, fine. They do things. They're kind of part of your lymphatic system. And it's less frequent now for people to get them taken out than it used to be, because we know that they do have some immune function. That's the end of the new stuff. And the big picture concept from this section is this: numbers and predicting what's the flow of tissue fluid in or out and what's the value. And also the lymphatic system, what is it for? What's it doing? Kind of big picture stuff. So come on Friday, review with Phoenix. Study for that Monday test coming up. And I will see you all, I guess, I will see you with tests in my hand on Monday. I'm going to tell you, like in the past, when somebody's had a depression, like I give them the option, you only take it one, two. And then you take either one that you feel better about, just do one on Monday, and then the other one, save it. Until you're feeling like all the other things. But I don't want you to take them both like in a short time frame. Okay. And if you, whichever one you feel more ready for, just let me know like Sunday morning by email and I'll bring that one to the. Okay, that's thank you. And it could be either one. Okay. And then if you want to wait like until the whole end of the semester to take the other one, you can. But it's just whenever it seems doable.
Like, I was thinking about that, I was like, so I study right now for the exam, and I studied for the two. So I'm ready, it's real, I'm even like this class, so.
Yeah, it's pretty fast. And sometimes like because everybody else is studying for exam two, and the reviews are gonna be about exam two. Like if that seems better, do that, but just let me know on Sunday night. And don't do both on the same day. I had somebody do that one time and I thought, oh no, it did not go well. It did not go well, so.